Good morning. I have some December updates, so we're going to jump right in. If you would please document why the massive transfusion protocol was initiated on any of your patients that have needed it. And then if you don't end up giving platelets and FFP, which is part of the protocol, if you would just say why you didn't end up needing them. And FYI, we are running low on O positive blood, just so you know. For hand surgery follow-up, Dr. McDonald is very willing to assist with hand cases that come in, but obviously he's not always on call. So the recommendation is this: if there's a patient in the ED that needs an emergent hand call, or if they have a hand injury, call the ortho on call, because there's a lot of basic hand things that a general ortho will field with no problem. If they feel it's too complex and does need a hand specialist, you can clarify with the ortho on call if they want to call Dr. McDonald themselves, or if they would prefer that you do it, and then you can act accordingly. If there's something that needs urgent follow-up but maybe doesn't need a hand surgeon that minute, Dr. McDonald asks that he be contacted either via Tiger Text, Message Center, email, text on his phone. He said we could send a hot air balloon to his house, like whatever it is, but let him know, because he does a lot of planning with his staff to make sure that the ED patients get followed up quickly. They do fast operative planning if necessary, but he has to know about it. So his fear is that if we say, hey, you can follow up with either the ortho on call or the hand specialist, that he may not know about it for a week or two. And if it's something like an infection or more urgent, he really wants to know. So reach out to him. If there's issues with that, let me know. And also, as a second opinion, if you think, oh, this does need a hand surgeon, he said he'd be willing to give that second opinion. So keep me posted. The troponin units are about to change. I don't think that'll be a huge impact, but just so you know. We are falling out still in sepsis. In October, we didn't do so well. We were doing great for a while, and then we kind of fell off a cliff, and we were 90%, and then we were 50%. So one of the big reasons that we have fallen out is that we are not documenting fluid exceptions. So you need to put why, the reason you're not giving the 30 per kilo, and then how much you gave instead of the 30 per kilo. So I think that's kind of the documentation that's needed to justify that. And then keep watching for any emails that come in from Stephanie Dana. She's trying to help us. For CT angios, we know that this is now a quality measure that's being looked at. It is going to affect our incentive metrics from the hospital. And so I think the best way to approach this is to have a local protocol that we follow. And I've looked at what ASAP recommends, and then they use the Society for Vascular Medicine guidelines. And so I'm going to give a brief summary of it here, but also we are sending out to your email along with this attachment, of a flow sheet for it. And then in the email here, I'm including a link. But basically, it's if you are assessing a patient with a possible PE, you should apply a risk assessment score, which is either Wells or the Geneva score. And depending on what they trigger, if it's low risk, moderate risk, or high risk, it'll direct your treatment from there. So if it's high risk, you go to CT angio. If it's moderate risk, then you can order a dimer and then act accordingly. If it's elevated, it's CTA. If it's not, you can be done with that. And then if they're low risk, you can apply the PERC score. And if the PERC is more than one, more than zero, you order that angio. And if it's not, then you can be done with your PE rule out. With anything in medicine, you are at the bedside, you're making the decisions, and you can order the CT angio if for some reason there's some exception to this, or there's another reason that you see that you really need it, but it needs to be justified. It needs to be documented, because a CT angio we know has inherent risks as well, with ionizing radiation, etc. And so I would like to see that documentation improve. We are including some of the utilization management insurance denials that have come through, as well as approvals and appeals on the attachment of this email. And it's more just for an FYI type purpose. I think a lot of it boils down to if we document better, we won't get denials. But also, I think there's some room for improvement on who we're exposing to radiation. And sometimes applying these decision rules will give us a little bit more of a roadmap for that. So we kind of have a baseline now. They're running more audits, and we'll see where this takes us. So I'm proposing this protocol be adopted. I would like you to review it and get back to me with any problems that you foresee. And then otherwise, we should go ahead and implement it. I would like you to get back to me by Monday. The other thing that we've got is a proposed chest pain protocol. So cardiology's looked at this, the hospitalists have looked at this, and it looks very reasonable to me. I would propose that we implement it as soon as possible. And if you guys would let me know, again, when you look at it, if there's any problems that you foresee. And otherwise, it does seem very reasonable. Anyone with kind of those intermediate risk heart scores, you are going to have to call the cardiologist, and we do recognize that there is quite a variability in their practice, but that's okay. They can decide, and that's what we've got. So let me know how that goes. Make sure you're documenting your heart score for every admission, because it does help. It helps us to get paid for the work we do. It helps the hospital stay afloat. And then I'm sending out another protocol that for buprenorphine for initiating it in the ED. And this comes from ASAP and EMRA. And Dr. Abid, the pain specialist, but also is actually an addiction medicine specialist, has reviewed them and thought they were reasonable. And so if you want to initiate bup in the emergency department for someone, this is a good starting place for you. And then also there are going to be a couple of clinic times that they are reserving for ED patients that we initiate in the ED. The clinic times are Monday and Thursday at 4:30 at the Rural Health Clinic. So if we can utilize that, that'll be a great service to our patients. Thank you for all that you do. Hopefully Christmas goes well. And then as always, if you have any issues, please let me know. I want to help. We want to try to work on processes and making things better. I am working on a lab process so that hopefully we won't have to babysit so much. And we're kind of looking at all the components that go into getting a lab done, from the order to collection time, from the collection to in-lab time, from in-lab to when it's supposed to be run and then resulted. And we're trying to hone in on where some of our places are that we are really falling out. One of the things that would help is if you guys could just grab a sticker, put an MR number, and I can put up a sheet, or if you can just throw it in my mailbox, it would be really helpful to kind of tag some of those outliers or those ones that you're having to babysit over and over, so that we can start seeing, is it a person? Is it a process? Is it a time of day? Whatever it is. So that also helps. Thank you again for what you do, and I'll be seeing you.